Good morning, Ms. Peterson. My name is Cheryl, and I'm a respiratory therapist, and I'm here to get a little information from you. Can you confirm your full name and date of birth?
Salome Peterson, June 11, 1986.
Thank you. Before I came in, I reviewed your chart, and I'd like to hear from you exactly what brought you here today.
Last night, my friends and I, we were out drinking, having a good time, and we went to go down this flight of stairs, and I tripped and fell down the flight of stairs. I instantly felt pain, but I thought it was just from shock from falling down the steps. So all night, it was hard for me to breathe, but I just figured it was from falling down. So this morning, I decided to come in and get it checked out.
Okay, I understand. I'm going to take a good look at you and get some more information.
When Cheryl came in and verified the patient's date of birth, name, and asked her to explain her injury, she could tell the patient was oriented ×4. Her appearance and hygiene are good, but she notices the patient is a bit anxious and seems to be in pain.
I'm going to start by taking your pulse.
Cheryl notices that the patient's pulse is regularly irregular, so she evaluates the pulse for a full minute and determines the patient is tachycardic.
Your pulse seems a little high. Let me check your blood pressure and oxygenation status.
Cheryl monitors the patient's respiratory rate by watching for the rise and fall of the patient's chest. Cheryl will count each inspiration inconspicuously in an attempt for the patient to not alter her breathing pattern. Since the patient is using shallow breaths, Cheryl evaluates for a full minute. The patient is found to be tachypneic. Cheryl checks the patient's brachial artery for a pulse. She then performs a blood pressure reading by placing the blood pressure cuff on the patient's bare arm, approximately 1 inch above the bend of her elbow. Cheryl places the stethoscope face down under the cuff just to the inner side of the upper arm over the brachial artery. Cheryl listens for the Kirchhoff sounds, noting when she first hears a heart sound, systolic, and when she no longer hears a heart sound, diastolic. Cheryl determines the patient is hypertensive. The pulse oximeter is an electronic device that evaluates the oxygen saturation of the blood. Cheryl checks the pulse oximeter reading, which indicates the patient has mild hypoxia. Assessing the patient's face and head, Cheryl notices a slight bluish tint around the patient's lips, indicating central cyanosis.
What I'm going to do is check the positioning of your trachea. I'm going to have to put my hands on your throat like this, okay?
The patient's trachea and jugular veins show no signs of shifting or distension.
Okay, I'm going to need for you to swing your legs over the side of the bed. Do you think you can do that with not much pain?
Yeah.
Cheryl takes a good look at the patient's chest and sees that the AP diameter is normal and there is no chest abnormalities. The patient is still tachypneic. Cheryl also looks for retractions and any other scars, tubes, masses, and she notices that there is bruising around the 8th ribs intercostal space on the patient's left side. Continuing with the chest assessment, Cheryl checks for any crepitus and evaluates tactile fremitus. There is no crepitus and unilateral decrease in tactile fremitus over the left lung field. She evaluates chest expansion and notices an increased thoracic volume on the left side.
I'm going to get a good listen to your lungs. I need for you, if you can kind of bend forward and put your hands in front of you like this. I need for you to turn your head to the side and take deep breaths in and out through your mouth.
When Cheryl evaluates breath sounds, she will start posteriorly at the base of the lung. She will auscultate in a symmetrical manner by listening at a specific spot on one side and then the same spot on the opposite side, noting any differences in sound. She will listen to 6 different areas posteriorly and 6 different areas anteriorly. Cheryl notices diminished breath sounds over the left upper lobe and crackles over the left lower lobe and decides to percuss those areas. Cheryl notices that there is a hyperresonant sound over the left upper lobe apice and a dull sound over the left lower lobe dependent regions.
Okay, you can go ahead and lay back down. I'm just going to take a look at your hands and your feet.
Cheryl notices there is no clubbing, peripheral cyanosis, or pedal edema, and the skin temperature appears to be normal. Evaluation of the patient's chest x-ray reveals a small pneumothorax at the left lung apice, a broken eighth rib on the patient's left side, and a hemothorax at the left lung base.
All right, Ms. Peterson, it appears that you have a fractured eighth rib on your left side. The broken rib will heal on its own in approximately 6 weeks. 6 weeks. It is recommended that you limit your physical activity and ice the area regularly to reduce the inflammation and pain. That fractured rib caused little internal bleeding, which has resulted in a hemothorax around your left lower lobe. In addition, you have a pneumothorax in your left upper lobe. The doctor has ordered a chest tube be placed in order to drain the fluid from the left lower lobe region. The pneumothorax in your left upper lobe region can be treated in 2 ways. We can wait for the excess air to completely absorb, which would take approximately a week or 2. During this period, we would have you on a nasal cannula at 2 liters per minute and take periodic chest x-rays to monitor the pneumothorax. Or we can physically remove the air trapped with a needle or possibly another chest tube. This would have to be placed higher since the air moves to the top apices of your lungs and the fluid, which is gravity dependent, is located at the base of your lungs.